Good afternoon, everybody, and welcome to Zahn Academy. I'm so happy to have Dr. Isaac Tawil here today, joining us on redefining digital dentistry, a clinician's workflow, and what a laboratory needs to know about photogrammetry. Dr. Tawil, thank you so much for joining us here today. We've been trying for
Mm.
months to get you here, so I'm so excited to finally have you.
Well, thank you for having me. I appreciate it.
Dr. Towle is a distinguished member of the dental community. He is a dentist who received his Doctor of Dental Surgery degree from New York University College of Dental Surgery and has a master's degree in biology. He also is the clinical director of TBS Dental in Shining 3D. He is the co-director of Guide Smile. And Dr. Tawil is the ambassador of the Megagen International Network of Educators and Clinicians. We're so happy to have you here today, Dr. Towell. And I just want to let everybody know that the doctor has prepared a few poll questions for us that I'll be launching throughout the presentation. So we'd love for you all to be interactive with us. So when I launch those questions, if you wouldn't mind taking a moment just to answer them for us, and we will be having a live Q&A at the end of the presentation. So at this point, I'm going to turn this over to you and have a great presentation, Dr. Towell. Everybody enjoy.
Thank you. Thank you. And thank you all for having me. It's a pleasure to be here with Zahn and as well with Henry Schein, as I am a long-term Henry Schein client, I should say. I don't like to say the word customer because you guys sell medical equipment, not you're not selling me a car. So, and I appreciate it because you help me make my day a lot easier every day that I go into my office and I have everything that I need. I love my sales reps that come to us and really support us. So thank you very much. And this is truly a privilege to be here with this group. We're going to be discussing a lot about digital dentistry as a whole and what Shining 3D and what we have done at Shining 3D to try to help you kind of take the difficulty out of a lot of these complicated cases and make it more simplified. We'll go over a few different things. As a disclosure, these are a lot of the companies that I work with. As you just heard, I am a consultant with several different companies, a lot of different digital companies. I've been working with digital companies for many, many years and trying to develop new products and some products from scratch as the alpha beta tester, others just as beta. I enjoy this part of the industry. It's a lot of fun to be behind the curtain on a lot of development of many of these products. One other thing that I love to do is publish papers. So you may have seen in Dentistry Today, you'll notice that a lot of these are going to be focused on full arch. That is my joy and my enjoyment because I think that area is very, very, very difficult for people to kind of take over. So we've been dealing with full arch for many, many years. We have dozens of articles on that. More recently, last year or 2 years ago, we had on Compendium, we were on the cover of that for our dynamic navigation for full arch. And then this year for digital, we're using the new Shining 3D Elite. And then as well on Dentistry Today, we made the cover on implant practice. We were featured, or I was featured. So it's been an enjoyable ride in dentistry, especially on the publication sides, both in the US and abroad. This article, which recently got published in March, and then there was a follow-up addition to that in April, was the important one for me because it was my first cover with my good friend, Dr. Scott Gans, and my colleague. We teach a lot of courses together, and we do a lot of digital courses. And it's a lot of fun to be on there with a CareStream scanner that he had been working with for many years, as well as myself. And then on the forefront, the Shiny 3D scanner, which I've been working on for many, many years now, for a couple of years, I should say, but the photogrammetry part of it for many years. We also, this month in Inside Dentistry, published another article as well, which is a beautiful thing to see. We're constantly getting a lot of attention and we're hitting the cover of a lot of these magazines because it's attractive. It's something that's really beneficial to the clinicians. So it's really taking us to that next step, that next level. When it comes to digital dentistry, and as it comes to anything in any field, we like to have things that are more based as an ecosystem. You may like Android, you may like the iPhone. It's good when you have an iPhone and then you have a Mac computer, maybe you have an Apple TV adjunctive to it. So everything kind of seamlessly works together. The same thing that can be said about digital dentistry. We like to be more of this ecosystem that works well. So Shine 3D has developed a lot of different pieces to this ecosystem, a facial scanner, they have some printers, they have different intraoral scanners, they have a mobile cart to kind of piece everything together. Those are the simplicities that doctors crave. We don't want to have to run around and get 10 different things that don't work together and try to make them and squish them together and merge it all to make it work. We want it to be seamless integration where one thing talks to the next and everything is just more simplified for us to be able to utilize. So why do we should even think about a facial scanner? A facial scanner has been a dramatic improvement to my cases, especially when it comes to full arch. Having the facial scanner is really helping me plan my cases properly. You can see as they were planning the building here, they didn't plan the name very appropriately, and the planning is coming down the side. That cannot happen in dentistry. We cannot start saying, well, we can just keep going and just keep adding teeth onto the right side. It's not predictable. What we need is something that is going to be more predictable, more reliable. Similarly, as we're building a house, we would have plans. We would have three-dimensional plans. We would know the concept of where the plan is. We could start looking at this pen to paper before we ever start taking a shovel and digging. So that blueprint is going to be the key to our success. Having all the records, so one thing that we need is typical x-rays, CBCT, will help us to diagnose the case. But without the rest of the face accompanied with that, we are unable to really see the true picture of what it would look like. Just like here, we have the blueprint on the right, we can see the house, we see where the car goes, see where everything is. But it's nice to see a three-dimensional rendering of what the house should look like. And now we can go ahead and treat the case. We can start digging, build our foundation, and move forward. So what happens when we don't have the right records is we end up with situations like this. Now here we have multi-units that weren't planned correctly. The transition zone wasn't planned correctly. And so now we're seeing the metal from the multi-unit. When we ask the patient to smile a little bit heavier, the Duchenne smile, we can now all of a sudden see that metal, which is not going to be helping anybody in the case. And the patient will now be covering their mouth instead of smiling brightly, or they will send back the case back to you to say, hey, can you add more acrylic? Can you add more porcelain? Can you add more ceramic filler to block out the metal, which leaves us in a very poor hygienic situation? So we have to see that patients are all different. Every patient has a different smile. Each one is different than the next. So we cannot just assume that one size will fit for every patient. We need to have all the records because this patient may be different from another patient. And we want to restore all the important goals for that patient, the phonetics, the function, the speech, how they are going to smile when they give us our biggest smile so that when we do complete the case, the patient is happy. That will lead to more referrals for our through our office. If we get more referrals, we'll be sending more cases back to the laboratory so they can be doing more and more good work for us. But when we don't have those right records, it's hard for us to say this patient has a high smile line, low smile line, and sometimes two-dimensional pictures just aren't enough to be able to determine that. Sometimes they are. So that smile line is going to be our key feature as to what we can do and when we can do things. Since we don't live in a two-dimensional world, photographs can only get us so far. When we now step into the three-dimensional world, we can truly digitize our patient. And if I'm a laboratory technician, if you give me a two-dimensional picture or a three-dimensional picture, I can see so much more from the three-dimensional picture just with my eyes. So that becomes a more of a perception versus reality thing. If we may think the patient is smiling fully or not, maybe we're not capturing it. It's great to be able to do a real, true analysis for that patient. So, for example, for this patient, we can incorporate all the different phases for him in one file. We can have a facial scan that is three-dimensional. We can then also include the intraoral scan and have that match together. We can crop out his smile and use his intraoral scan smile. We can overlay the CBCT, can have this all in one file. And in the end, we can get numerical data, where his line angles are, where our tragus is, where his Frankfurt horizontal plane is. We can look at all these different aspects, interpupillary diameters, and we are able to now hand this over to the dental technician for them to be a better evaluation for the case. And that can lead to restoring smiles. And I like to say very often, we like to change lives one smile at a time. As a dentist, that's where I stop. I stop at the face here. I don't go up to the eyes, the noses. I can't deal with that, but I can fix the smile. And we can take a patient that was basically a dental cripple and give him back a smile that they deserve. A new added feature that is coming out next month in July that you should be aware of is the ability to do mandibular jaw tracking with these cases. We are now able to do dynamic occlusion, vertical dimensional analysis, and dynamic jaw tracking. We can overlay, since we have all these scans, overlay the facial scan to the intraoral scan and the CBCT and put the patient through movements so we can analyze the condylar position. This was only available through a couple of select different devices that cost tens and tens of thousands of dollars. Now this can all be simplified in a simple software and all bundled in one for a much more affordable solution. And we can actually track the position of the jaw. So we can see if the patient is already in temporomandibular dysfunction, or if they're in a good position, we can analyze their vertical dimension. This is all wonderful to be able to say to our patient, you know, you have TMJ already, you have temporomandibular dysfunction. Maybe we shouldn't open up your bite. It's going to make you worse. Or let's fix your bite first. Let's get a new analysis, check the condyle position, and see if that helps your bite. And this will prevent, hopefully, a lot of difficulties and breakages of a lot of materials down the road as we keep progressing. So why should you even think about Shining 3D compared to any other intraoral scanners? We've developed many scanners over the years, and thankfully, the latest scanner does not have to deal with anything like impression material. You see this long impression material in the mouth. We've developed a really nice, cool intraoral scanner that's small, lightweight, unique, has the ability to do a lot of amazing technology. There are lots of different intraoral scanners. We started with our aoral scan. Our 2 was our first successful one, and then a 3 wired and wireless, which gave us a real good oomph into the market that we actually can make really good scanning products. And then, of course, the latest development is the photogrammetric portion of that, the combination unit, which we'll discuss a little bit more as we move along. So we have truly come a long way at Shining 3D. We are able to do all the traditional things. This is not just a photogrammetry machine. It is one of the best scanners on the market. In my opinion, it is the best scanner, but I am biased, so take that with a grain of salt. But we can do a lot of amazing things. We can do all the basics that we need when it comes to intraoral scanning. We have the Elite scanner. It has a really, really impressive form factor to it. It's lightweight. It's the lightest scanner on the market. It's a metallic frame. We can get very, very deep into hard areas. So this is showing an implant super deep, but imagine trying to get those deep margins for single crowns. We have amazing technology with our structured light scanning, and we are available in all the different formats, STL, OBJ, PLY, so you can open this in your third-party software, such as exocad, 3Shape, Dental Wings. And it's nice about this device is it's USB-C only, takes power only from the computer USB-C port. You do not have to have an extra battery pack. So portability is a really nice feature to this intraoral scanner. What really shows me if I can do some good work is or have good accuracy is if I take a case that is a timed case, meaning I'm going to engage the timing of the implant, the hexagon, the trilobe, the octagon. When I take my records, if I get a really good scan, if I can go straight to a final for a 3-unit screw retained engaging uh, um, bridge, then engaging abutment, then I know that I'm getting some really good accuracy. And as you can see here, you can zoom in again. Just look at the fine detail that this is giving you. You can almost see the screw hexagon inside the implant. Obviously, we use scan bodies, but you can just see how well it captures the sulcus so deep into that area. And we're able to go directly to the implant fixture with this device going with a 3-unit bridge. I wouldn't go more than 3 units. I don't believe that you can capture accurately more than that, but we can be truly digital. We did this case modelless, and we are able to make a 3-tooth fixed partial denture, screw retain with engaging abutments. You see on the lower x-ray there, the hexagon has not been removed. It is in there, and it was engaging that conical connection as well. So that shows me that the scanner is pretty accurate, but only for a limited field. I wouldn't go more than that. If any of you know Wally Renee, he is a brilliant educator. He just had his Mod Institute symposium. He is so big on this scanner. He loves this scanner, and he loves to make 3D printed dentures. He teaches dentists how to do their 3D printed dentures same day. It's an amazing technique what he does, but he's using our scanner to do it. And he's using the big head on the scanner. We have three different tip sizes. One of them is meant for photogrammetry. He uses this for his denture scanning. And he's showing the heat map here and the alignment. And really, he's been bragging about the scanner for so long that it's really a great scanner. He has said it's the best scanner for complete edentulous arches. It's insanely good for removables. So it's not just for implants. It's not just for crown and bridge. We can do some amazing stuff. We don't have to take a impression and scan an impression to make a denture. We can use this device along with proper retraction. That's going to be the main thing. Proper retraction, so we can capture all the vestibules. A lot of times, this does mean that we have to turn the artificial intelligence off on the device so that we can capture the mucosal area. The scanners like to block that out, but this shows us that we can do this accurately. And if he gives a thumbs up, then you can take that to the bank because he's very, very hard on products, especially new products. We do have an update to the intraoral scanner. We did make it wireless. We did cut the cord. It is slightly heavier, but is the lightest intraoral scanner on the market currently that I'm aware of. It's really, really impressive in that we can get this lightweight body, sleek design. It's just a little bit bigger than the wired version. Obviously, we have to fit a battery, so it's going to be a little bit bigger. Has that multifunctional touch button and all the great features about it. But the main thing is, what can it do? Can it scan full arch captures? Can any scanner capture full arch scans? And I've been working on this for many, many years. I've published many articles about that. And the main problem that we have is as soon as we extract teeth, once we remove the teeth, those are our markers, those are our landmarks, and we lose tremendous amounts of geometry. Now we have to rely on tissue, and tissue is movable. Tissue becomes the issue. We end up starting to have our reference frame completely lost. We start scanning on one side of the mouth and we start scanning on the other, and the scanner now thinks you're still on the other side of the mouth, and it just keeps flip-flopping back and forth. And very often you have to turn AI off, scanning these edentulous areas. So it's very hard because it struggles to stitch. And we see this in our daily lives. We try to scan, and I was on a team. I don't want to say the scanner's name, but I was on the development team for the scanners that you're seeing here. And we realized once we lack keratinized tissue, everything gets very hard. Can it be done? Yes, but I have to go slow and struggle. I need something that will capture quickly and accurately. And that becomes a problem, especially when it comes to full arch scanning around implants. So we've come up with lots of different designs and ways. I used to use rubber bands and things like that to try to carry me over. We've used tags, ortho wire, you name it. Up in the top left, there's my friend Jonathan Oppenheim used to do his composite curve to try to get some accuracy on that. It's very difficult. And we've come up with different type of scan bodies and things over the years. I helped to develop the IO Connect system, where I helped them. I didn't develop it. I helped them improve the IO Connect system. There's the Glidewell fast scan bodies at the top. There's Scan Ladder. I developed those ones on the bottom left. That's the Arch Bridge. I wrote the first paper on the bottom one called the OptiSplint. The Nexus iOS. They haven't opened it up to a lot of labs because they know they're not perfect. It's hard for them to capture everything in that realm, and it's not the fault of the device. Device is fine. The Scan Ladder, Nexus, all of that, it's great stuff. The problem is that we only get a good amount of capture on it because the scanners can only be that good. And roughly, in my own studies and other papers you'll see, we can get to as good as about 80 microns worth of capture using these devices. Now, that may be good enough. If we look at the literature, it tells us that if we have under 150 microns, then we can capture full arch of implants without any issues. So is 80 micron capture sufficient then? The answer is that it's unfortunately not. This is not the only error that we have in the process of making a full arch prosthesis. If our threshold is 150 microns, then we don't have a lot of leeway if our initial capture is taking up almost half or more than half of that error margin. We need to have more cushion to be able to capture so if we can have less error at the time of capture, we will have a better outcome and less chances of issues, let's say during the milling phase or the CAD CAM design phase or the matching stages that occur. So if we look at this kind of like a funnel, all these different errors can lead to a final misfit that will kind of break everything down. And at this point, we don't know where the problem is. And it's kind of like playing Jenga. If you pull the wrong piece out from the puzzle, then everything kind of crumbles down. So we need to have as little discrepancy at the time of capture so that we can have the best amount of success and leave more room for other things that may have errors, such as milling errors that may occur. So it's more important to me to start off in a very positive, successful capture, and then later on, if there's any issues, I'll be able to match up with better. I'll be able to catch up with it. So all the research, I don't need you to look at the papers, all the research ends up telling you that a lot of these scan bodies and all these different scanners, they're scanner dependent. Some scanners are better than others. Not every wand is the same. Harry Potter's wand may be better than somebody else's wand. So it's important for us to really look at that as a whole. Some scanners are inexpensive but scan really well. Some are super expensive, but they really don't scan that well, and they're selling them for very, very high price margins. So when it comes to full arch, it could be a problem. It's a single tooth, yeah, they'll all work fine. The user's experience level. I mean, I can't tell you how many people I see scanning and they're just not scanning correctly. They don't understand the philosophy. The original scanning path was to scan in a certain type of a path, and the oral environment conditions may not allow you to do that. So a user has to be able to navigate through the difficulties, such as the dreaded tongue, saliva, blood. All of these things create more of an issue. So the scan path that we choose ends up being the most important thing. And for me, I see all these videos of scan paths and they say, yeah, just scan the occlusal, then go to the buccal, then go to the palatal or lingual. That's actually not the right way to scan. Depending on the scanner, most of the scanners will stitch pretty well, but you want to give it as much field of view as you can. So as you're scanning, you're rotating the scanner around on the buccal and lingual, so you're capturing a little bit of each, so that when you do stitch, it will stitch and merge better. And I think our scanner does a really great job of stitching. But no matter how good you think you can do at stitching, it's not always perfect, and that becomes the problem. So the quality of the stitching becomes our main concern. How good of a stitch do we really get? So if we think about this logically, something that we all do every day, we may use Google Maps or Apple Maps, and you may look at the satellite view. And this is Google Maps, which has very, very high technology. But look at the circled areas. These areas are deviating. They did not line up and stitch correctly. So it took a picture here, it took a picture there, and it didn't match up. So obviously the road on the beach does not just drift off into the middle of nowhere. It doesn't drop off a steep curb. That road on the left side is not driving right into a house. It's not a driveway. This is the errors of stitching. And even the house you can see is not done correctly. And here's just a picture of a baby. There is no baby. I really hope that that's nothing doesn't exist in real life, because I'd be quite scared. But there is no baby that looks like that. I hope there is no centipede baby that is out there on the market. And this woman who was on vacation, she's taking a panoramic picture of a selfie picture. I mean, I can't imagine that that's what she looks like. Otherwise, she needs a little bit of plastic surgery, I would have to say. So this is the problem with stitching, and we all have these panoramic phones, these iPhones and Androids that can stitch together nicely, and we see these beautiful pictures, and we look at them and they look like this. They say, "Wow, what a great picture!" But I'm looking at everything on the right and on the left, but everything was really just all in front of me, and it was actually not, it wasn't a U shape. Why is it U shaped? It's because it's stitching and it's building up and trying to build around this algorithm. If you look at this picture here, this is my father on the right side. He does not look like that. My child on the bottom does not look like that. My brother-in-law on the left side, his hand is not, 2 feet long. This is the errors in stitching that we have. And when you go to the Santa Monica Pier, take a beautiful picture. It is not a U-shaped structure. We do not see cars that are shortened like that and elongated in others. This is the problem, because when you're stitching together, there's movement that's occurring. The patient's mouth may move, the tongue may move, and this is going to create stitching errors. So stitching cannot be the solution until the algorithms catch up and improve. Do I believe that one day intraoral scanning will be good enough for all of this? Yes, I do. But is today the day? Unfortunately, it's not there yet. So what do I need to be a full arch clinician? I'm going to place full arch implants. What are the tools I need? And it's a lot. It's a lot of software. We need CBCTs, need implants. We need all these different devices, instruments, and all of this stuff. So if we can simplify it, would be better. But some of the things that I want to be a full arch clinician and do same day surgery revolving me around using two specific devices, one intraoral scanner and one photogrammetric capture device. This together in combination will get me below that 150 micron threshold easily, probably put me below 30 microns and give me that extra cushion I need to be able to scan capture with ease. So if we do these types of cases, when we employ photogrammetry, we have to start to understand what photogrammetry is. So photogrammetry is an industrial solution, and it is used using accurate measurements of known objects. Sorry, I think I have a pop-up here. I have to navigate around. There we go. That has these known measurements. It collects the 3D data by analyzing those spatial relationships, and it's using the overlapping images. So it is stitching, but stitching very differently. It's stitching using mathematic algorithms, and it's only taking pictures of known objects. So it's taking, let's say, a marker that I put in an area and another marker, and it's measuring the distances between the two. So it's not just capturing them, but it's capturing them by mathematical data positioning. And it's using multiple cameras to do that. It can be 2 cameras, 3 cameras, 4 cameras, depending on how far you are, the more cameras you want. The closer you are, the less cameras that you need. So what is extraoral photogrammetry that we utilize in dentistry? You'll notice that I don't call it photogrammetry, I call it extraoral photogrammetry because now we've introduced intraoral photogrammetry to the marketplace. And basically, extraoral photogrammetry is basically those two separate devices. We have that extraoral camera that is held outside the mouth, which is the EPG, and then we have the intraoral scanner that will capture the known objects in the mouth and the tissue and or everything else around it. So the extraoral photogrammetry will only capture, you'll see I'm holding this device outside the mouth, you'll see these green flags in the background. It's blocking everything else out in the background. And while the intraoral scanner will capture the soft tissue, we may want to use some scan bodies or healing caps to give us some form of alignment. And then we'll have to do a matching in a separate software, a third-party software, to match those pieces together to be able to go ahead and design a case. When we look at the research, there is no doubt if you compare any of the scanners to photogrammetry, no matter which photogrammetric system you use, we are much more successful using these flag systems. Some of the flag systems, they're all vertical here. Some of them have like more of like a flag type, some more have more of a domino type shape, but they utilize these two concepts, intraoral scanning and then photogrammetry, and then combining them together in a separate software. The research is undoubtedly there. Photogrammetry is superior to capturing implant position as compared to intraoral scan. And again, the reason, we remove the geometry in these cases. They're implant cases. We have no geometry. All we have is the implant positions, and we're using scan bodies that look exactly the same. So we're stitching one on top of the other, and we're trying to align this data. And unfortunately, the stitching, as I showed, is not always perfect. So the photogrammetry here, as we're capturing, you can see here we're on the extraoral positioning here, and we're getting that known data. It will turn green once you know that you are successful. In other systems, it'll make a noise or a ding, and now you'll be able to overlap. But sometimes I have some trouble capturing that back implant you see on the left side, on the bottom right, but on the left of it. It's hard to align all that data together. This object is a little bit heavy, and I'm trying to link everything up, but eventually I can get it, and eventually it will give me a data output that can be quite accurate. And now I can take these 8 implants and start to make my design once I have converted all these files and matched them together. This conversion and matching and file alignment can take some time. This is not seconds, this is in minutes. And I do have to speed it up because we don't have that much time, but you'll see the process that goes on in this case. And this is one of my favorite photogrammetry units, the iCam. It's a wonderful device, works very well. It's a bit pricey, but it works very, very well. And we're doing the data alignment so we can match the intraoral scan with the scan bodies or healing caps if you'd like. And we can match those two tissues, and then we finally bring it into the software. And this is using a good friend of mine who does this very quickly, and he did it in around 14 minutes and 55 seconds. That could be fast for some people. That could be, maybe some people take a little bit longer. Some can do a little faster, but that's about roughly amount the time that it takes to merge these files together. And again, you have to merge files. You have to find the files, have the files. Did they send the right files? That becomes more of the annoyance of it. So we end up having some of these errors that can occur in that as well. Some people say, well, can I go direct to implants using photogrammetry? And there are a couple of systems that do, and I would highly recommend against it. When we're looking at implants, each implant has a connection. So I either have to get rid of that type of connection, that triangle, that octagon, that hexagon. I'd have to abandon that connection and go directly to the fixture without that connection because of a lot of the angles that can be there. All these different angles. And as a lab technician, you look at this and say, what the heck is this? I mean, this is prosthetics gymnastics, as my friend Scott Gans likes to say. How do you overcome all these hurdles in a case like this? Very difficult. You can have facial access holes that are going to look terrible here. They're going to have to try to go and correct. And even using multi-unit abutments in this case might be difficult because how do you even bring those over? You need 90-degree multi-unit abutments for these cases. Hopefully they make it for that implant. The other problem that really becomes an issue to me, and one of my biggest fears, is that when we have an implant and we're going direct to the fixture, we can break the screw. And if we break the screw inside the implant, sometimes it's like this, where we can see it on the middle, we can get them out. Other times it's so deep that we cannot get them out. And now what do we do in those cases? So I'm not a big fan of that. I'm also not a fan of going direct to the fixture because I'm putting extra stress on the fixture itself, and that could lead to the implant fracturing. And these are game over situations. If a screw breaks and I can't get it out, hopefully I have enough implants I can get around it, but it's game over. I gotta ditch that connection. I can't use it anymore. If an implant fractures, it's trouble. Do I have enough implants to get through the case? Can I use it, or do I have to start over? And this has kind of been the bane of my existence. So I'm really not a fan of going direct to fixture. I'd much rather have an intermediate abutment, which is my solution to overcoming this direct implant phenomenon. So instead of sectioning up bridge work and trying to get that done, we follow the all on four type of technique. We can do more than four. We can do 6, 8. We don't have to angle. We can put everything in straight. I like to use straight multi-units whenever possible. And then once we get to this multi-unit level, we then can go into that next step and decide how we even want to temporize the patient. Maybe I want to temporize them same day using some passivity that I can get because I have a proper line of draw using the multi-unit abutment. So this really takes me to that next step where I can do immediate provisionals, whether they're prefabricated or, as I'll show you, post-fabricated. I'm a big fan of post-fabricated 3D printed restorations for same-day designs. So the multi-unit abutment to me is that solution. Sorry, I got to click through this. Let me see if I can get rid of this. Sorry, I have to jump out to get rid of that slide there. Hopefully you can see everything here. So the multi-unit abutment does help me out a lot. It gives me the ability to have better passivity, increased passivity. I can do angle correction if I'm using different screw systems. There's screws like Powerball, Vortex, Rosen, Des that give me angle corrective ability. So I can, if I have a multi-unit, it's straight, but it's going to come through the incisal edge, I can angle correct with those screws. If I have a straight multi-unit, I want to change it to 17, I can change it to 17 and correct my angulation. It gives me that nice feature. It doesn't disturb the soft tissue because I'm not taking the abutments in and out. So I'm not disrupting the area around the implant connection. It makes it easy to retrieve because I can just remove the Teflon tape that's blocking it, unscrew everything, clean it if I need to, if I find that there's some gingival irritation. And that helps me for my long-term maintenance. If I need to remove it and add some material because I have a little shrinkage, I can do that all by with simplicity as opposed to going direct to the fixture and keep stressing that connection over and over and over again. I can change these screws. They're not terribly expensive. And it's easy to get them out. And if these screws break, I can get them out. Or if the multi-unit is damaged, I can change the multi-unit. It's kind of my fail-safe. So for those that like to go direct to implant, I just feel like they haven't done enough implants and they're worried that maybe they can't do like an FP1 restoration. We do FP1 restorations all day long. Fixed prosthetic one, white teeth, no gingival replacement, all day long, and you'll see a case later on today that's an FP1. So what is intraoral photogrammetry and how is that different than extraoral photogrammetry? We developed this system using the intraoral photogrammetry system from Shining 3D, utilizing horizontal scan bodies. We take these horizontal scan bodies, we can place them into the mouth, we line them up towards the center to give ourselves the best area for us to be able to capture overlapping data. It uses that same technology, and then we can take that and we can do some really fun things once we have an intraoral scan in this data. So basically, we've taken extraoral photogrammetry, we brought it in the mouth to do intraoral. So basically, we're turning it 90 degrees. Where we were extraoral with vertical scan flags, now we're intraoral with horizontal scan flags. That gives us the ability to overlap the capture and gives us the precise capture of not the implants. Never with photogrammetry, unless we're going direct to fixture, do we go direct? Do we call it implant position? We call it multi-unit abutment position because what we're really capturing is the multi-unit abutment. So always recommend to tell the clinician, please torque down your multi-units again before you do your record capture. Make sure everything's nice and tight because what you're capturing is the multi-unit position, not your implant position. So make sure that you have that done correctly. So intraoral photogrammetry, we have this device. It's two photogrammetric cameras in this device. We have three intraoral cameras in this device. It's a really, really nice combination of these two units. And we're able to do this using a technology that we like to call video stream-based photogrammetry. And this video stream-based photogrammetry, you can see here, you have the three cameras. This is how it works. We would have three intraoral scanning cameras and two photogrammetric scan cameras. So that's the basic idea behind it. And what we can do now when we have these cameras, so it is true photogrammetry, we can identify the markers. We can say, hey, I only want you to scan these markers when I'm using the photogrammetry portion of this software. I want you now to place those markers, and whether it's in the industrial sector, as you see down at the bottom, or in dentistry, where we're installing them in the mouth on top, we can capture boats, planes, objects. It makes no difference. It's the same ideology and same technology. We then pick up our magic wands and we go ahead and we capture in the industrial sector. We would use these handheld devices that go around the boat, around the building. In the mouth, we're using a intraoral scanner basically that has this photogrammetric component. And then we can interpret all that data inside the software to give us the precise implant position or multi-unit position. And we work with all of these different companies. We have different kits. Some are available, some aren't FDA approved just yet, but this is all what's coming. And it does get a little confusing because Straumann, is on both sides. They have an A kit. They also have a D kit. They were compatible with both. So you have to know which multi-unit you're using. So it's important to you to make sure you have that one. Make sure they identify it. Hopefully they have a label of what their multi-unit is before they send over a case. But you want to know which one it is, and you want to know which scan body they're converting to make it easy for your system. We have a whole library of scan bodies that we can choose from. So basically, we've taken one device and we've given it two functions. We have the intraoral scanning function, in which we do not want any scan bodies. We just want to scan tissue. And then we have the photogrammetry portion where we're scanning the multi-unit position. But the beauty, what we can do that no one else can do, is we can match these two structures together in the mouth. Because we were using the same device, we can scan, capture, and do the alignment already completed for you so that this does not have to be done in a third-party software. Once we have that data matched, we can do a simple conversion to the scan body. We can take these scan bodies and convert them to Nobel scan bodies, DES scan bodies, ELO scan bodies, whatever you like. If you like to use the Vortex screw, we got the Vortex library. It's all in there so that when time it gets to the lab technician designer, they already have the scan bodies. They can attach the multi-unit, get to work, and start doing design instead of having to do matching. So this is about how long it takes. You find the files. Once the clinician sends over the files, you go ahead and pick your antagonist. You might pick your Pontics and all of that. And this is more real time. And then it opens as fast as your computer can open it. So this is about 40 something seconds, and we have all the files stacked and matched all in one file. makes it much easier, and you guys can do what you really want to do, which is get to design, get to work instead of matching, which just takes a little bit of cumbersome time. If it didn't match correctly, of course you can realign it, but at least what I've seen is that they come through all the time matched properly. So we have three different types of sizes. We have 9 of these scan flags slash scan bodies. They're dual purpose. We have a small, medium, and large, and that helps us to get closer to each other so we can have more overlapping in our scanning. And we made an extra wide window. This, when they're using the photogrammetry one, they should be using the 19 by 14 window to be able to go on top of the scanner of the objects and start to measure out the distances. And as it's scanning, it's going to, with the photogrammetry, it's going to measure the distance of the dot and say, hey, I know you. You are A2. A2, I know you, but it won't import it until it sees a neighbor. And it sees its neighbor, it'll say, hey, I know that you're C3. So A2 and C3, I know you're there. But what I have to figure out is what is your distance between each other? And so now the last step of this before it will import it into the software is it'll make sure it has enough data between these implants, between these multi-units or scan bodies, and it will only populate once it knows the actual distance. This is really helpful because it's using mathematical algorithm instead of scan matching. So there's lots of different workflows that are out there for EPG, for horizontal scan bodies, for OptiSplint. Ours are simple. When we're doing fixed provisionals, we want facial photos or a facial scan. We want an intraoral scan for a healed ridge with the prosthesis in the mouth. We want a scan of the opposing, a scan of the bite. We want a scan of the MUA tissue, but no caps in place. We do not want any tissue caps. We then want a photogrammetry scan. And then our last scan is we do not need a reverse scan of a temporary prosthesis because we already have this all lined in the mouth. We could skip that step. Whereas with the other ones, we do need a 360 scan of a provisional prosthesis. So let's take you through this healed ridge protocol. You can see here on the screen here, it'll break it down very simply. I'm going to scan the existing restoration. We're going to scan the opposing arch. We're going to scan the bite. So we have the restoration, we can see the tissue, we capture as much tissue as we can, we have the opposing, we have them in occlusion. We then remove the restoration and we capture just the soft tissue as is, no scan bodies on top of it. We'll insert those elongated perpendicular scan bodies slash scan flags. We will capture our photogrammetry. We can then go through the matching feature within the software to match it to the soft tissue. We have our conversion tool to scan it to the appropriate scan body. So make sure to tell the clinician, I want you to use DES or ELOS or whatever you like to use. It automatically identifies the tooth numbers for you, so that doesn't have to be done. And we can export this all in one project file for this easy opening. So here we are, we will scan the provisional, and this is important to capture as much tissue as possible. In the maxilla, it's easier, we have the palate. In the mandible, it's more difficult. We have the mandible, make sure we capture enough soft tissue of the mandible. We scan the opposing, which we'll do, and we'll also scan the bite. Here, it will match the bite very, very easily. Works very fast. Now we can remove the prosthesis from the mouth, and we can start to scan just the multi-unit position. I do not want any scan bodies. I do want some soft tissue so I can align my pre-op with the provisional to my current removal of the prosthesis. So those two will align nicely. So you'll see here, once I hit play here, it will now give you a heat map showing the layering of the two. So we're very, very nicely matched with our provisional and our multi-unit scan. We then insert the photogrammetry pieces. I scan 9 of them here. This is a big case. And we go ahead and start capturing the photogrammetry positions, getting as much overlapping data as possible. And what you'll notice here is I'm capturing and it's importing them based off of me moving from one to the other. So I get enough data. I'm working on high speed dubbing here. This is not real time, but I'm going back and forth capturing the data. And then you'll notice one of them is showing up in a gold color, meaning we have an alignment there. It's not perfect. So maybe my multi-unit is not torqued down. Maybe my scan body is not tightened down enough. This is something I need to check, or maybe I just need to give it more data by going back and forth between that scan body and some of the others again, which is exactly what I did. I went and I scanned again, going back and forth, getting some more data between that scan body and its neighbors. And then sure enough, it gives me the sign that I have enough data and I'm good to go. So this is how it shows us if we're accurate or not. We then will do our scan matching, and we'll do a couple of them here. We start scanning and you notice the alignment. It's kind of like taking the occlusion, the bite. In this case, I did 3 of them. You can only do 2. You can do 4. You can add as many as you like. There is a plus button to add more. And now I have my all-in-one project file. I've converted everything over into the scan bodies that I like to use. And I have my bite. I have everything stacked. So it goes over to the lab for our next design, and they will then send me back a design to approve. And here I have 9 implants. I buried 1 implant, as you can see, 9 implants sitting very nicely and accurately. And I used a metal-free zirconia here, all zirconia, no metal whatsoever, because I can be accurate enough. And in this case, I use something called the Vortex screws. I hope you know about those. I'm happy to talk to anyone about that if you're unaware of what vortex is. And you can see the bite. This is the best part. The bite's always just like dead on. I never really have any issues. Obviously, he has some broken teeth on the bottom he has to take care of, but his excursive movements, everything is all captured nicely, and we're ready to roll for a healed ridge. So what about surgery? It's the last component of all of this. Surgery is more difficult. We have a lot of different issues. It's very hard to do that matching that I just showed you because we may open a flap and the tissue may be all over the place. We have to deal with blood. Blood is going to make things very messy and hard to capture. We have a very harsh environment with the tongue. The patient may be sedated. It's kind of like going to battle with like war when you're in surgery and you're pulling the cheek and stretching and pulling all that tissue around. So it's very hard sometimes to even get access because we may have a bite block in the mouth to try to capture. All of these things make it harder, including the motion artifacts and, of course, the scanner itself, the time and pressure from surgery, all of these things. It just, even just talking about it now just stresses me out. Even though I love doing full arch, the thoughts of all these difficulties just make me uncomfortable. So, we have to also worry about the scanning and stitching errors from there. So for surgery, since matching is very difficult and often not possible, and since we're extracting all teeth, how can we maintain the workflow from the pre-op all the way to the post-op? The answer is we need to use fiducial markers. You can do a pre-op CBCT and a post-op CBT and match them together. I've had many patients faint on me in standing up taking a post-op CBCT. So I'm not really not interested in taking a post-op CBCT, but that is one method. Could you use a denture and do a realignment with healing caps? Yes, but to me, that's not fully digital. I want to be fully digital. And so how do we go around this? How can we merge these scan bodies? By using fiducial markers. There are lots of different fiducial markers on the market, but we can go from this patient with teeth. If I keep those fiducial markers as a reference, preferably more than one to give me some triangulation, and I go to post-surgery, I have those together, I can have great success. So the surgical protocol involves inserting a fiducial marker and then scanning that to the existing situation, whether it's a denture and you carve a hole in the denture and capture that fiducial marker, or whether you're going ahead and matching it to teeth. We also have within the software an internal scan. We can scan the intaglio of a denture and match it to tissue, but that doesn't help me if I'm going to destroy the tissue, right? So it really does need something that's going to be there from beginning of surgery to the end of surgery. We scan the tissue or our denture with the fiducial marker. We scan the opposing arch and the bite. We then extract all the teeth, and we can now go ahead and place our implants, multi-units. And at that point, we can do one or two things. We can try the scan matching and try to match to our fiducial marker, or we can do something new, which is the cap scan body. This is something that we developed to help match the photogrammetric pieces to the actual tissue. We convert those scan flags to the scan bodies. It identifies the tooth numbers automatically in the software, and we send the all-in-one project file over to the designer. And hopefully I get a 1-hour turnaround design, and I can print in my office very quickly and give my patient a same-day provisional. These are some of the fiducial markers that I use. If I can keep a tooth till the end of surgery, it's great. I'll do that. A surgical bar, arch tracers, the AIM screw, bone screws, ortho screws, printed objects, any of these things will work very, very, very well for us to be able to capture and align all of this data using scan matching. But when we can't do scan matching, we really need something else that will help us. And that became our solution for same-day provisional surgery, which is basically the following. We will scan to the fiducial marker. We'll scan the teeth to that fiducial marker. In this case, we have two fiducial markers that you see in the upper right corner there. We took a facial scan for the patient. We're going to remove all his upper teeth. And then we can do, again, one or two things. We can go through the workflow for the scan matching if you want. But I suggest for surgery, and only for surgery, to use the CAP scan body solution. The CAP scan body has to be erased from the software. You have to bouillon it out. So it's better to use this in a non-healed ridge. In a healed ridge, I rather use the scan matching above. But in a surgery, I like to use the CAP scan body. It makes it very easy. I take that initial scan with the fiducial marker. I take my bite. I take my occlusion. I take my opposing, and my bite, my occlusion. I then go ahead, extract everything, put my implants in, and I have my photogrammetry captured. And then I go ahead and I use these CAP scan bodies that will align the data together, which I'll show you in a moment. So let's take you through that real quickly. We'll go ahead and on the order form, this time select the CAP scan body option and also a pre-op. We'll also pick which scan body we want to utilize. Now we can capture the bite. Because I'm going to put the patient to sleep, I can do the alignment later. I can also go ahead and capture the teeth, and then I can put the patient to sleep after all this is done when I insert my fiducial marker. So we're capturing the opposing here, and then we'll capture the fiducial marker. Sorry, here. This is going a little bit faster. Here's the fiducial marker, which I showed you before. We put the patient to sleep. We captured the fiducial marker area. And then we'll go ahead and go to our next scan, which will automatically align. Now, when it doesn't automatically align, it's okay. I can hit the automatic alignment button, or I can do point matching. I can pick object number 1, which is that molar, number 2, 1, 2, 3, and have it automatically align as well. So if it doesn't match the software, we can align. Then you'll notice that there are these dominoes there that look a little different than the other elongated dominoes that we have there. So let's go through that part. Basically, what we've done is we extracted the teeth, we placed the implants, we did our capture of fiducial marker, we put our photogrammetry flags in. You see on the bottom right, we're capturing that photogrammetry. But now what the main thing is that circled fiducial marker at the top is matching to the post over there. And if we only missing right now those photogrammetric matching. So the only slide that are missing right now is for that third picture on the top to be linked to the fourth picture. And that's what those CAP scan bodies will do. We will go ahead after we suture everything up and we will capture. This will take you through the workflow here. It'll go and capture all the tissue, and then we will CAP scan each one of these and they will turn blue. You don't have to get all of them. You only need 3. But if they all turn blue, you're going to get perfect alignment every time. And if you don't, it's okay. We have a manual option as well for that. So we built all this in so that there is a fail safe just in case. But you can see everything's lined up and matched nicely to where now all the layers are matched. Our initial scan with the fiducial marker, our photogrammetry, and of course our tissue scan. So we have all 3 scans in one file so that you can start designing right away. In this case, I picked the vortex screw, but everything is aligned. So imagine getting a file like this already lined up. And now what do you have to do? Start designing your prosthesis so that the doctor can start printing. If it doesn't match, you can go ahead and select. We can go ahead and pick. We go to one object, select it. And the other, we'll pick another one, select it. And then another one. And it will get alignment automatically. So we have that option too. So matching the pre-op to the post-op is very, very simple. When we have it, we can do it manually. We can do it automatically. We get those objects matched. So by the time it comes to you, you can even do the reverse of it. You get them to you, it is already aligned and ready to roll. We can start designing. At that point, you can send me back a file. I can start printing. I can print very, very fast. In this case, I printed with our printer for same-day provisional. Took me under 20 minutes to print and wash, and then we cure. We get this nice provisional. And then, oh, sorry, I'm out of that again. There we go. And now I have this healed ridge waiting for a temporary teeth. I remove, not healed ridge, this sutured ridge waiting for temporary teeth. I remove these CAP scan bodies that we use only for surgery. We insert an FP1. You can see the implant seating is quite nice on the lower x-ray. Everything's looking really well. You bring them back. You can see the bite was pretty good there as well. And we can bring him back and see the post-op. He's healing pretty well for a patient. And this is the cancer patient survivor who was getting some teeth. So he's ready for teeth, but this is the surgery, and we were just talking about surgery. So you can see how he left very happy, not missing teeth. And I didn't have to use a guide for this. I was able to do this free-handed. I have to do an intraoral pickup. I just made a printed provisional. So our advantage here, instead of doing prefabricated with stackable guides, really becomes very important. We can do everything that we can do with prefabricated guides using this system. We can do FP1, 2, or 3 cases. We can reduce our fabrication time down dramatically under an hour because of the fact that these files are aligned. Our surgery length of time can be reduced because I don't have to do intraoral pickups, which is really nice. And I can go grab a cup of coffee for a half hour, 45 minutes till I get my design, and then my team can start printing. I can be seeing other patients, I can be doing billing, whatever I'd like. I'm not committed to any implant positions because I'm not scanning till later. So I don't have to worry about that. As opposed to intraoral pickups, I need to be within the framework of that structure. The quality of my temporary is superior these days. And the other part of that is I can print as many as I want backup. So if a patient breaks it, I just print a new one. And it's for pennies on the dollar. And ultimately, my case acceptance has dramatically increased because I'm getting really nice outcomes on these cases and getting a lot of referrals and being able to make lots and lots of backups. So where we have problems at Shiny 3D, we look for solutions. And we did that with our team at Shiny 3D and all the different array of products that we have to help. And what I like to do is treat all my cases similarly. We look to create solutions all the time. So what I ask you to do as well is don't look for problems, find solutions and create your own solutions. So with that, I will stop and we can have a little bit of Q&A. I'm sure there's some questions here. I'm happy to go over any questions. Hopefully I didn't go too long. I apologize if that was a little bit lengthy. I know it's a lot of information. Definitely a lot of information, but hopefully you got the gist of what we're trying to talk about. I'm happy to have any follow-ups with anyone who is interested as well.
Excellent, Dr. Towel. Thank you so much. While people are preparing their questions, you could just type them in at the bottom of your screen, and Dr. Towel will be happy to answer any of the questions that you have. I just want to go over some of the polls that we had. So
Sure.
what the first one was, has anybody, any of our listeners prepared cases with photogrammetry? And I was surprised to see that 67% have and
Beautiful.
3% have not. So I just wanted to see, what your thoughts were on that. I was kind of surprised with 67%. That's awesome.
That's fantastic. That means that we're doing really well because photogrammetry is the commonplace for a full arch, and you're getting enough clients that are utilizing this technology. And these clients that you have, these clinicians that you have, they might find this to be a great solution for them. If they are not interested in switching, that's fine. But if it helps you move along your workflow faster, maybe that will entice them to want to come on over. Because what I found is where with photogrammetry, I was waiting, sometimes 2, 3, 4 hours for same day designs. I mean, my designer gets it back to me in like 15 minutes. We do a pre-op DSD. We get all this data over, and it just flows right through back to us, and we can start printing. And about 95% of my cases are leaving in about 45 minutes with teeth after
Wow.
post-surgery. Post-surgery, obviously. Surgery could be 6 hours. It could be 2 hours.
Right.
It's all dependent upon the situation. But that's a really nice thing to see. And for those of you that have worked with photogrammetry, you know the struggles of trying to match everything up. Imagine not having to do that part of that work. Some of you may be experts at it and you may not want that to change. You may feel like your job is in jeopardy. It's not. We're just trying one technician when he opened it up and he said, "Oh, expletive. I think I might be out of a job." I said, No. We made your job much more productive. Instead of doing one case an hour, you might be able to do 3 or 4 cases an hour. You're that good of a technician. I don't even like to call them technicians. You guys are designers. Yeah, you're really designing teeth. So should you be spending time doing the menial labor stuff, or should you be spending time on working on pontics and spacing and all that to make the teeth look really, really nice? That's the goal here. And then think about it on the other end. There's a patient in the chair sitting there waiting. They want their teeth, they want to go home. They don't want to be there and sitting there bleeding and all that. And you don't want them in their office that long. And if it's a next day design, I never want to see my patient next day. Next day, I'm doing the surgery. If I was just a restorative dentist, it's okay. Come on in and you can complain about how mean that surgeon was yesterday. And now you're all black and blue and you bled all night. But
Yeah.
when I'm the treating surgeon and also restorative dentist, it's more like, oh, I'm so sorry. And oh, I can't believe that happened. I'm so sorry you had a rough night. Not every case is like that. A lot of cases we're fine. It was great. It was much better than I thought. But there are those that are not happy the next day. And as they say, absence makes the heart grow fonder. So for me, I find a 10-day post-op, everybody's very fond of each other, assuming everything's going very well. And they start to stop worrying about the swelling and all that because that's subsided. The pain is gone. Now they're just coming in and they're talking about, I love my teeth, but could you make this one a little bigger? That's what I want to see, or that's what I want to hear. That's the kind of feedback. And I don't have to deal with that uncomfortableness of, hey, I'm sorry I beat you up yesterday.
Yeah, it plays on you, when you see somebody
Yes,
that
absolutely.
uncomfortable the next day or complaining the next
Absolutely.
day, I can definitely see that. Um, the next question was post-fabricated provisionals, are they a better option than prefabricated? And 85% say yes, they're
Good.
much happier with
Good.
the
I agree. And I agree with that because of the fact that we're getting these quality temps. We're actually putting people into some degree of function. We may wipe the occlusal tables a little bit, but you're starting off on that path where now when it's time to make the final prosthesis, I may not even need to make another provisional. I may just scan that, see the difference in the tissue height. I always recapture implant position. I want to retorque my multi-units, but it's a quick visit. And then maybe I can go straight to my final zirconia. I may skip a visit, skip a printed try-in if everything is going well. Double arch, I never do that. But single arch, everything's great. Patients loving me, loving the teeth. I might go straight to the final and just make a copy.
yeah. Are you okay with clinicians printing in office? 29% are neutral, 57% approve, and 14% disapprove. So I was happy to see the approval rating is 50% as well.
The neutral part, I think, is also interesting because I think that are people that are on the fence. I think they're afraid that, hey, is my job in jeopardy again? Let's face the reality. Milling is getting cheaper. Printing is getting cheaper. The restorations that are coming out that are not FDA approved yet, but that I have in my office, those as well. Those are now becoming for final usage. We need to adapt. Our future in the lab industry is going to be in the design portion. It's going to be maybe even working from home a lot. I know you're working from home a lot these days as well. You mentioned to
Yeah.
me, I've been to the Medford facility a while back, and things are closing up. It's not like it used to be. Maybe it's good to work from home, right? You can do designs and all this stuff from the comfort of your couch and be that person that is going to help to finalize the case instead of just saying, oh, I also got to print it. I also got to work with my hands all the time. There's always going to be the dentists that want to do zero lab work. Those are going to want shipped products. But the younger generation, they love printing. They're already printing toys. They're buying frozen printers and printing things for kids, or printing even their own toys and objects. I see
Yeah.
people that print Star Wars figurines all the time. This is the reality of the future of the next generation that's coming in. And the current generation is ready for that too. That we are kind of poised to take a lot of the lab work away, but the design work is where it's at. And soon with AI design, it's going to make you even more powerful and even faster. So you're going to be even more the ability to do greater amount of work in a shorter period amount of time. So think of it that way. Don't be afraid of the printing world. Don't be afraid of the milling world either. If they want to do their lab work, okay, it's a headache anyway. Let them deal with it. Get to the computer part, the part that that you were born to kind of do, the part that we want nothing to do with. There's always going to be those that want to do design too. I don't want anything to do with it. If I could, I would do without. If you can, somehow teleport a object over and I had to do zero lab work, I would much rather that. So it's either teleportation or let me print here because I need it now so my patient can leave.
Yeah. Yeah. I just want to let everybody know, well, you too, Dr. Towell, that this is definitely being recorded. We have so many questions coming in because I think that there was a tremendous amount of great information that people are saying, please send me the recording so that I can rewatch this. So I have a feeling that There are going to be a lot of people rewatching this, and I will let everybody know that probably in the next day or so to check your email, and that would be the email that you replied, that you registered for this particular course with, and you will get the recording whether you were here live or you weren't able to make it today. Definitely there will be that recording that you could watch over and over, and I can let you know, doctor, that we will probably get some questions that I'll have to send over
So
to you for some.
what I would suggest is I have no problem with you sharing my email out to the public that's here. Feel free to email me directly. Let me know that this was the webinar you watched. I have another webinar tonight at 7 for clinicians, so I want to know where you came from. So
Mhm.
which lecture I actually gave. That one's even if you thought this was detailed, you have to see the one tonight. These are for experienced photogrammetry only. People that have been using photogrammetry for years and they want a high level. So those, I want to know where you came from, know how to phrase the question. So just say, hey, I'm from the Zon webinar, and please, if you can answer this question about me, and it can be now, it can be later, it doesn't matter when. I'm happy to answer any of the questions.
I just want to let everybody know that we have a hands-on surgical guide course that's going to be coming up at the ASIGA headquarters on July 18th. That's going to be a great course. It's, featuring ASIGA, ExoCAD design, as well as Zerlux print resins. But we are having an hour, maybe a little bit longer lecture with Shining 3D. A representative from Shining will be joining us there to go over photogrammetry, intraoral scanning, and do a demo as well. So that should be really interesting. That's at ASIGA, their brand new headquarters, and that's going to be taking place July 18th in Ann Arbor, Michigan. And you can go to our website to learn some more, and that'll take you over to the Eventbrite if you'd like to sign up for that course if you're in that area, or you'd like to see, beautiful Ann Arbor. It's a beautiful place to
It is
visit.
a beautiful place. I've been there.
Yeah,
It's quite beautiful. Yep.
it's fun, the
Yep.
University of Michigan right there. It's very,
Hmm.
very cool where they are. And again, this is something that will be, kind of hands-on. You'll be able to work with the scanners and the facial scanning as well. So that'll be a really interesting course.
Terrific.
Surgical guides and photogrammetry as well. So we're so excited to bring that to you all. And there's so much more coming up on Zon Academy for the month of July and August. So, please take a look at our website once everything is loaded in. We also have now 0% financing for 12 months. I'm not sure, this is something that's very new, and we can offer this with your Shining 3D purchase if you're interested in purchasing one of these scanners. So there were many of you that said that you were interested, and I will, once I get all of your information, me personally, Fran, will be calling you just to discuss with you what those options are, what you're actually looking for, and how we can get this into your laboratory or your clinic as fast as possible. And with 0% financing for 12 months, it's a great financing option that we can easily send in some paperwork to Henry Schein Financial. One form you find out by the end of the day if you qualify. So that's just a little something that can help you, like I said, get this great technology into your clinic or your laboratory, as soon as possible. I think we have another question. Oh, so everybody is saying thank you so much, Dr. Tawil. They really appreciate this. Again, I'm sure you'll be getting questions because people are going to be watching this. I'm going to watch it again. It's just a
It's a
lot of
lot.
great
It's a lot of
information,
information. Yes. So
a
I'm
lot of
happy it's
great,
being recorded.
and it's from the clinician's point of view. So we can't thank you enough for joining us. We finally got you. It's been months and months and months. I've been trying to rope you into Zon. I finally got you, and we're just so happy to spend a little bit of time with you this afternoon. So thank you so much from all of us here
My
at
pleasure.
Zon. I wish everybody listening a great rest of your afternoon, and I hope to see you again very soon. Thank you all.
Thank you.